Alright, how's it going, everyone? This is Michelle and Byron. We're doing our presentation on spinal cord injuries and also concussions in football. Alright, so right here it's just our objectives that we're going to talk about, mechanism of injuries, then we're going to present our research findings, and then we're also going to give you guys a little bit of history and some important rule changes as well. Alright, so what we have right here is a little bit of information on axial loading. This is the primary cause of severe spinal cord injuries, not only in football, but also in all sports in general. Another way to think of it, as I have mentioned in the second sentence, is this is also known as what's called spearing, and that's basically leading with your head down. Defensive players, as I put in, are at high risk, but offensive players that are also unaware are at even higher risk. Basically what that axial loading does, just puts a lot of compression through those vertebral bodies, and that increases the risk of paralysis, fractures, etc.
So we have here a couple examples of spearing. We're not going to show them to you on this YouTube clip, but we will show them to you when we're all in classroom together.
Alright, so right here we just have some basic concussion information. We're all familiar with what a concussion is, the type of injury that it is, and how long it does take to get back from a concussion. So basically, just to refresh everyone's memory, I just put just a little bit of questions, just some basic info about concussions. That it is a traumatic brain injury. It can occur not only through direct contact to the head, but also the shaking of the head or the upper body, and just so everyone knows how serious of a matter this actually is. So once again, just about disc herniations, just refreshing everyone's memory, how there are 4 types. I also put the picture of Tony Romo up there with his issue with his herniation, just in case Rose is out there watching this video as well. I stole that picture from her. So yeah, basically it's just refresh everyone's memory on what a disc herniation actually looks like, and just once again how serious of a matter it actually is on the football field. Alright, so just another one, just refreshing everyone's memory. It's just a spinal fracture. We all know what a fracture is. We all know how serious a fracture is. The picture on the right is a football player at Tulane University a couple years ago that actually fractured, I'm pretty sure it was C4, C5, and just his struggle, just trying to get back. Also, when we actually have a workshop, I'll actually show you guys his video and how his recovery is actually going in his daily life as well.
This is just a fun little picture to fill up space, and hopefully you guys get a little chuckle out of it. This was pulled from the NATA's position statement, the acute management of the cervical spine injured athlete. It talks about a little bit about prevention and planning and rehearsal. Something that was also in the article that I didn't put under planning and rehearsal was that the rescuer should also be familiar with the NATA position statement on emergency planning in athletics. So for the assessment part of the slide, I pulled that right from the article. It's important. It's things that we should all be able to recognize to provide the best care to our athletes that we can. For stabilization, the only other thing that I didn't put on there was that we should not apply traction while we're stabilizing. And for the airway, they said that we should remove clothing and equipment if possible, and that advanced airway management techniques are recommended in the presence of an appropriately trained and certified personnel. That would also help the airway. So you guys can read this slide too. I'm not going to read it to you. The only other things I'd like to add was that for manual stabilization should be resumed after the application of external devices. Sandbags have been used in the past to aid in mobilization of the head, but they tend to be heavy, so should not be used anymore. And also that full body vacuum splints tend to be more comfortable for the athletes, but I know for a lot of us we won't have access to those. For the equipment removal, they suggest a powered screwdriver is the best tool. It's the quickest and causes the least amount of movement, but you should also have a backup cutting tool available in case batteries die, equipment is rusty, and that they should also use corrosion-resistant hardware. So I'll let you guys read most of this one too, but acute management, I just wanted to expand upon that a little bit. Hypothermia is thought to be a potential treatment for this because it may slow the rate of inflammation and the or decrease oxygen demand, which could potentially help the athlete. There are a lot of questions surrounding it that they don't know the answer to, like what would be the optimal temperature and duration? Would local or versus systemic be better? How soon after injury should this be applied? And what's the best way to rewarm? Because there is such insufficient evidence, this isn't something that is used. As far as the high-dose corticosteroids go, there was a study that showed that a high dose of methylprednisolone within the first 8 hours of injury had significant neurologic improvement at the 6-month follow-up compared with the placebo group. But upon evidence-based reviews, serious flaws in the data were shown, and there is actually no real support for using corticosteroids. This is from the Summary of Evidence-Based Guidelines, Evaluation and Management of Concussion in Sports. It's pretty self-explanatory, so you guys can just read it. And these are just different diagnostic tools and their sensitivity and specificity. We should be familiar with them, but I thought it'd be interesting to see the numbers and why we use them. Note at the bottom, a combination of diagnostic tools are suggested to improve diagnostic accuracy for concussions. You guys can read this one too. And for recommendations, the biggest thing that they're pushing right now is education. The school-based professionals, athletes, coaches, athletes' families, etc. And also that the athlete should not be returned to play until they have been cleared by a licensed healthcare professional.
Alright, so this is another study that I found. I just put just a little bit of brief information about it, so you guys just have just something to look at. When we get to the workshop, however, I will explain about it a lot further, because I do think that it is important that we know how the NFL has been treating injuries such as, in this case, cervical disc herniations. Alright, so right here I also just threw in the inclusion criteria, just broke it down a little bit. It was a small sample size, however, guys, because they only took players from one team for this study. Obviously, keep it nice and small, since it's the very first time. But yeah, I just wanted to throw this on there so you guys knew about this as well. Alright, and right here I just put just a few results, because there were several results from all 16 different players. So, right at the very top, the most common symptom was radiculopathy, so we're all familiar with that. And then also put in how a couple players, retired, did not return to sport, had to go through surgery, and other stuff like that. And then right here, as you see, they're all in quotation marks, so I took these straight from the article itself. But this is just the conclusion that they came up with. It's pretty broad, pretty basic, nothing too special, but just once again, I just wanted to show you guys this article to let you guys know that this matter is being taken seriously.
Here's just a brief history. You guys can read it. It's from the NATA position statement on head down contact in spearing and tackle football. Here's a little bit more history. You can see some of the changes that were made in the different timelines. Notice that in 1976, the NCAA implemented spearing rule changes, and this was possibly one of the most important rule changes that has been made. Here's a little bit of data. The first hard-shelled helmet was implemented in the early 1960s, so you can see some data on that, what the effect that had on the game was, and different injury rates. And then 1 year after the 1976 rule change regarding spearing, incidents of quadriplegia in high school and college athletes decreased by 53%, and by 1984 the number had dropped to 78%, so this is huge. And just some recommendations that they make to help promote the safety of our athletes. Just more education of officials, of coaches, of athletes and their families. They also said that officials should be more consistent and strict on penalization for spearing. This is kind of hard because, you know, some people spear intentionally, some people spear unintentionally, and you know, how do you differentiate between that, and how do you penalize accordingly? Also, the neck strengthening program, and the coaches should teach and enforce the see what you hit concept. It used to be face the numbers, but they thought that that would allow people to hit with a face mask more. That they felt like that's more what it was teaching, but see what you hit keeps the head up and out of the way, which is the proper technique when you're tackling.
All right, so right here, we just have our citations of all our studies and articles that we found. Once again, you know, when we're actually at the workshop, we'll go further in depth into each one, answer anybody's questions if you guys have any, and then, you know, also, like I said, show you the examples of each type of mechanism to you guys as well.